All right, welcome to the Explainer. Hey, if you're a nursing student about to start your OB clinicals, or maybe you're right in the middle of them, then you are in the right place. Today, we are breaking down one of the most critical skills you're going to master, the comprehensive newborn assessment. So let's just jump right in. Picture this. You're in the delivery room. A baby is born. What do you do first? The clock is ticking, literally. Those first few moments are everything, and what you do is all about a super rapid, super focused assessment. You're trying to figure out, how is this little one handling life on the outside? So here's how we're going to tackle this, just like you would on the floor. First, we'll cover those first critical minutes. Then we'll get into assessing core vital signs. After that, it's the full head-to-toe survey. And finally, we'll talk about measurements and maturity and how to pull it all together. All right, section 1, the first critical minutes. We're talking about that rapid evaluation right after birth. Your whole world shrinks down to 3 things: their breathing and heart, their muscle tone, and are they staying warm? Really, you're asking one big question. Does this baby need help right now? And your first tool for this is the AP-GAR score. Now, it's not a crystal ball for the baby's future, okay? Think of it more like a quick snapshot, a progress report, at 1 minute and 5 minutes of life. It's all about guiding your immediate actions. So what goes into an AP-GAR? Well, it's these 5 things right here: heart rate, respiratory effort, muscle tone, reflex irritability, and color. For each one, you give a score, 0, 1, or 2. Then you just add them up. It's like a universal language we use to quickly say, here's how this baby's doing. Okay, so you've got this number. What does it mean? Well, it tells you exactly what to do next. A score of 7 to 10? Awesome. That baby's doing great and just needs routine support. But if you're looking at a 4 to 6, that's a sign of moderate difficulty. They need some help. And a score from 0 to 3? That's a 5-alarm fire. That means severe distress, and you need to start resuscitation immediately. Now listen up, because this is maybe the most important thing to remember about the AP-GAR. It is a tool, not a commandment. It never, ever replaces your clinical judgment. Your eyes are your best tool. If you see a baby that's limp, blue, and not breathing, you don't stand there with a stopwatch waiting for the 1-minute mark. You act immediately. Okay, moving on. Once things have settled down and the baby is stable, it's time to get our foundation in place. And that means assessing their core vital signs. This is the baseline for everything else we're going to do. First up, we're looking at respirations. And you've got to count for a full minute. No shortcuts to get it right. You're looking for a rate somewhere between 30 and 60 breaths per minute. Next, you'll grab your stethoscope for the apical pulse. Same deal. Count for a full 60 seconds. At rest, you should hear a heart rate between 120 and 160. And finally, temperature. We do an axillary temp, that's under the arm. The sweet spot we're aiming for is between 36.5 and 37.5 degrees Celsius, which is about 97.7 to 99.5 Fahrenheit. All right, vitals are on the board. Now for the main event, the head-to-toe survey. This is where you really get to put on your detective hat. You're going to learn how to spot what's totally normal for a newborn versus what might be a sign of a problem. Okay, one of the first things you'll notice is color, and you need to know the difference between 2 types of blue. First, there's acrocyanosis. That's just bluish hands and feet. Super common, totally normal in the first 24 hours while their circulation gets up and running. But then there's central cyanosis. If you see blue on the lips, the tongue, or the main part of their body, that is a major red flag. That means not enough oxygen, and you need to act fast. When you're checking their cardiovascular system, don't just stop at listening to the heart. You have got to feel for pulses. You're going to compare the brachial pulse in the arm with the femoral pulse down in the groin. They should feel equally strong. If those femoral pulses feel weaker, that's a big deal. You have to report that because it can be a sign of a serious heart defect called coarctation of the aorta. You're going to see a lot of funny shaped heads, and that's usually from the trip through the birth canal. But you have to know the difference between 2 common findings. You've got caput succedaneum. That's just some swelling. It feels a bit boggy, and it crosses the suture lines on the skull. It goes away in a day or 2. Then you have a cephalohematoma. This is different. It's a collection of blood that does not cross suture lines. It feels firmer, and it can take weeks to resolve. And because it's old blood, it puts that baby at a higher risk for jaundice. Okay, let's talk neuro. You might see a newborn that seems kind of jittery or has tremors. First thing you should think is, let's check their blood sugar. But how do you tell if it's just a benign tremor versus something more serious, like a seizure? Here's a super simple trick you can do right at the bedside. Just gently hold the shaky arm or leg. If the shaking stops, it's almost certainly a tremor. If it keeps going even while you're holding it, that could be a seizure, and that needs an urgent workup.
Let's talk about jaundice, that yellow color. It's really common for babies to get a little bit jaundiced after the first 24 hours. That's just their liver getting up to speed. But here's a hard and fast rule. Jaundice that shows up within the first 24 hours of life is never normal. That is always considered pathologic, and it's a critical finding you have to report right away.
And here are just a few more of those call the provider right now red flags you need to keep an eye out for during your head to toe. Things like persistent grunting or flaring when they breathe, a fontanelle, the soft spot that's either bulging out or sunken in when they're resting, a crooked face when they cry, not peeing or pooping within that first 24 hours, or a sunken-in scaphoid abdomen, especially if they're having trouble breathing. All of these are major warning signs.
All right, last section. We've gathered all this amazing data from our assessment, so how do we put all the pieces of the puzzle together? That's where measurements and assessing maturity come in. This is how we build the full clinical picture.
So you're going to get out your tape measure and scale. You'll carefully get their weight, their length, and the circumference of their head and chest. And then you compare these numbers to the normal ranges you see here for a term baby. Oh, and a quick pro tip. Don't freak out when they lose a little weight at first. Losing up to 10% of their birth weight in that first week is totally normal.
And here's why getting those measurements right is so important. You're not just writing down numbers to fill out a chart. You're taking those numbers and plotting them against the baby's gestational age. This lets you classify them as either SGA, small for gestational age, AGA, appropriate, or LGA, large. And why does that matter? Because that classification is like a roadmap. It tells you exactly what potential risks you need to be monitoring for, whether it's hypoglycemia in an LGA baby or hypothermia in an SGA baby. And this really brings it all home, doesn't it? The whole point of this comprehensive assessment, it's not just a checklist you have to get through. It's about synthesizing all these little details to build one big, clear clinical picture. It's the skill that lets you tell the difference between that's just a normal newborn thing and uh-oh, that's a red flag. This is what empowers you to reassure a nervous new parent, to anticipate what a baby might need next, and to know without a doubt when it's time to call for help. For all you nursing students out there, this probably looks pretty familiar, right? This entire assessment, it's the clinical judgment model in action. You recognize cues like that jitteriness, you analyze them, could be low blood sugar, you generate solutions, let's check a glucose and maybe feed the baby, you take action, and then you evaluate the outcome. Did the jitteriness stop? It's that constant loop of thinking and doing. It's what it means to think like a nurse. So we'll leave you with this final thought. Your assessment skills, the technical stuff, they are absolutely vital. But knowing the difference between a caput and a cephalohematoma is really only half the battle. The other half, and it's just as important, is how you communicate what you're seeing. How do you take that knowledge and use it to calmly explain things, to educate, and to reassure a brand new parent during what is one of the most incredible, but also one of the most overwhelming times of their life?